Hi, I'm Deb Smith. I'm a licensed psychologist and board certified behavior analyst in behavioral health at Neponset Health Center, and I'm going to speak to you today about depression. First, I'd like to give credit for the resources that I used in developing this presentation. So, resources came from the certificate program in primary care behavioral health out of the Center for Integrated Primary Care from the University of Massachusetts, the Hunter Goody Ort and Dobmeyer book, Integrated Behavioral Health and Primary Care, and the Depression Management Toolkit, copyrighted by the trustees of Dartmouth College. Today, I want to briefly define depression and different categories of depression, the rationale for why we want to target depression in primary care, assessment of suicide risk, and a brief discussion of treatments. So, what is depression? Depression, when we talk about depression, we're primarily talking about major depressive episode, which is characterized by a depressed mood or a loss of interest or pleasure for at least 2 weeks, in addition to four other symptoms. These include weight changes, sleep disturbance, psychomotor agitation or retardation, feelings of worthlessness or guilt, or reoccurrent thoughts of death or suicide. These symptoms do not meet the criteria for a mixed episode, that is, a bipolar episode, and these symptoms need to be causing clinically significant distress or impairment in either social, occupational, or other important areas of functioning, not due to substance abuse or a general medical condition, and not better accounted for by bereavement. So obviously, after we've lost somebody that's close to us, we're going to have a depressed mood and depressed affect, and we may have, psychomotor retardation. But these but in order to diagnose major depression, these symptoms would have persisted after 2 months, or a marked functional impairment or morbid preoccupation with worthlessness, suicidal ideation, again, psychotic symptoms or psychomotor retardation. Dysthymic disorder is differentiated from major depressive disorder in that the depressed mood presents for more days than not over a period of at least 2 years, and the symptom free intervals are not lasting any longer than 2 months. Depressive disorder NOS is a bit of a catch-all. So this may be recurrent brief depressive disorders. These may be minor depressive episodes with with patients meeting the criteria for less than five of the items that are required for major depressive disorders. And the depressive disorder is present, but the clinician's not able to determine whether it's primary or whether it's due to a general medical condition. And then the last depressive disorder is adjustment disorder with depressed mood. So, this is in response to stressors that result in a development of symptoms such as depressed mood or tearfulness or feelings of hopelessness. Some comorbid conditions that can also be present: hyper or hypothyroidism, as well as hypo and hyperparathyroidism. Also, some infectious diseases such as HIV, hepatitis, mono, vitamin B deficiencies. So they have that listlessness and lack of energy that is also characteristic of major depression disorders. Again, other comorbid conditions can include stroke or traumatic brain injury, as well as substance use, excessive caffeine use that may be interfering with sleep, or excessive alcohol or hypnotic use. So it's important to be able to recognize and assess for depression in primary care. We know that there's increased risk of depression in patients with congestive heart failure, diabetes, COPD. This makes sense because these are conditions that can impact the patient's relationship with the environment and restrict their activities that they may have previously felt enjoyable, and they have less access and less opportunity to engage in these activities and to be reinforced from the environment. It's also important to recognize that patients with chronic illnesses and depression, chronic illness as well as depression, are 2 to 5 times more expensive, for lack of a better word, than patients with chronic illness alone. So targeting that depression makes good sense from a cost prevention standpoint. Depression is a common factor in patients disabled that are qualify and receive disability, compared with patients that are equally sick but not disabled by hypertension, asthma, arthritis, or ulcers. Again, targeting that depression can impact on a patient's ability to function. This slide addresses the cultural impact of depression. So when you're assessing your patients from both Western and non-Western cultures, it's important to note that changes in appetite, sleep changes, psychomotor agitation or retardation, not being able to get out of the bed, decreased energy, decreased libido, a diminished ability to think or concentrate. These are signs of depression that are found cross culturally, as opposed to the signs of depression found in Western cultures that are more typical of what we think of when we think about depression: the self deprecation, I'm worthless, I can't do anything right, nobody appreciates me, hopelessness, guilt, or suicidality. In terms of the prevalence of depression, there's a lifetime prevalence of 16.9%. Prevalence of symptoms for those being seen in primary care settings range from 10 to 30%. And as in anxiety, sometimes patients are having to present repeatedly in primary care before those symptoms of depression are recognized and treated. So, one of the ways to address the underdiagnosis is to have a universal screening of all patients in primary care. So, screening is basically the assessment of a population to determine whether the individual patient or the patients that are seen at a particular institution are at risk for a particular problem. So, purpose is early screening and intervention. Screening may narrow the focus of a diagnostic assessment. Screening is different from actual diagnosis. In diagnosis, you're going to consider a lot more factors than just maybe how a patient answers 2 questions or 9 questions on a screener. But the way that those patients answer that question may provide a forum for discussing the diagnosis with the patients. And also, screeners have a clinical utility. Repeatedly screening a patient may be a way that you can demonstrate that your patients are in fact responding to treatment. One example of the screener that's used at Neponset is the patient health questionnaire. It is the first two questions of the PHQ-9. It's got 87% sensitivity and 78% specificity for major depressive disorder. So sensitivity refers to if the test is positive, you have the disease. If the test is negative, you don't have the disease. So how accurately does it report true positives as well as false negatives? And specificity refers to if the patient doesn't have the disease, how often will that be a true negative? So so the PHQ-2 has 79% sensitivity and 86% specificity for any depressive disorder, and in older adults, 100% sensitivity and 77% specificity for major depressive disorders. So it's a pretty clear evidence that this is a good screener for major depression. In introducing screening to adults, one approach would be to just have a general approach. We routinely give this screening to our patients, so this may be the first time you see them, as a quick way to better understand some of the difficulties people may have, in addition to those we discuss in our visit. And if you have a client, a patient who you've been seeing for a while, but you are concerned about some symptoms, so you could give them specifically to assess. One script you might use is, I'm concerned about how much stress you've been describing in your life and would like to see if you would take this short screening questionnaire. It would help me better understand your situation. Here is the interpretation for the PHQ-9. So you see in the they're going to be rating it. Look on the left-hand side of the box. They rate on a scale from 0 to 3. And then on the right side of the box, in terms of the depression severity, it ranges from none all the way to severe depression. So in terms of communicating the screening results, you might say something like, based on your report, it appears that you are reporting a moderate amount of depression in the past 2 weeks. Would you say that was accurate? And then you can go ahead and discuss recommendations. We have many options. We can help you focus on your most frequent symptoms and their severity through a combination of behavioral and medication-related strategies. This slide is from the Depression Management Toolkit, and you can obtain it online. But here is on the top half of the table, you can see where you can use the PHQ-9 looking at the initial response after 4 weeks of an antidepressant. You're looking for a drop to less than 5. You can see here that if it does drop, then less than 5, that's adequate. A drop of 1 point or no change, inadequate. And then what the treatment plan would be. Then this augment, switch, maybe add psychological counseling. On the bottom half, it's the initial response after 6 weeks of psychological counseling. Again, if it drops for 5 more points from baseline, adequate. 1 point or no change, then we would consider referring for evaluation for medication, or maybe switching treatment, or maybe switching therapists. Teenagers are also an important population in addressing depression. So the recommendation is the U.S. Preventative Services Task Force recommends screening adolescents age 12 to 18 years, providing that systems are in place for further evaluations, psychotherapy, and follow up. So, this is an important point that you don't just screen for the sake of screening, but that you actually have a protocol in place for how to follow up if the screening is revealing positive results. Fortunately, at Neponsit, we are able to provide pediatric psychological services, but we don't have a specialized pharma- pharmacological services for teens. When your patients meet the criteria for major depressive disorder, or patients that you are reporting or who are reporting symptoms of depressed mood, it's always important to assess for suicide risk. And this includes any history of psychiatric diagnoses, any previous suicidal behavior, abuse history, any current precipitants of suicidal ideation, in terms of relationships, financial or health stressors, as well as affective symptoms like sadness, anger, irritability, or feelings of hopelessness. You want to look at the frequency, the intensity, the duration of thoughts, the specificity of these thoughts. The more specific, the more risky. Access to method and intent, as well as previous suicidal behaviors and any preparatory behaviors, getting their will, giving away possessions, looking at the degree of impulsivity or in self-control that the patient has, as well as protective factors. What are the clients, what's this patient's particular support system, and what supports are in place that are going to help this patient manage these feelings. So, in terms of in rating, this is a severity scale. This might be a nice scale to use when you're evaluating whether to send a patient to the emergency room or calling in the BEST team. Some It ranges from just non-existent all the way to extreme. So severe might be suicidal ideation is frequent and intense and enduring. There may be some preparatory behavior, multiple risk factors and few protective factors, all the way to extreme. So you've got a plan with an intent, impaired impulse control. You ask the patient what stops you, and they respond, I don't know. No protective factors. This is a patient that's going to need, obviously, a more intense level of care and support. So, in terms of management for depression, efficacious intervention for major depression include problem-solving therapy, interpersonal psychotherapy, and pharmacotherapy. Possibly efficacious interventions include cognitive behavioral therapy as well as cognitive therapies. For treatment, if started on medication, be sure to assess adherence to medication and ask the patient if they have any concerns or questions regarding medication, and providing psychoeducation around both depression and the initial response to medication. We know that it takes a while for these medications, for the patient to feel the effects of these medications, and being sure that they have some realistic ideas about the timelines and when they can expect to feel better. Also providing some behavioral strategies and some psychoeducation around that depressive spiral. You know, the worse we feel, the less we do, the less we do, the worse we feel. So one way to kind of reverse that spiral is through behavioral activation, that just trying to get up and get moving. If it's just being able to walk for 5 minutes a day, getting out of bed, taking a shower. You know, the more we do, the better we feel. The better we feel, the more we do. That's one of the things that we look for and we try to do, is to get these patients activated as quickly as possible. So key points, for major depressive disorder, that you need, patients presents with depressed mood, plus there needs to be that impairment in either social, occupational, or other important areas of functioning, and always, always, always assess for safety. Thank you for your attention.